I was hoping you could start by explaining the importance of your study. Natural language processing of radiology reports improves identification of patients with fracture.
Sure. First, I'd like to acknowledge Professor Chris White, who's the senior author on this paper, who was really the driver of this project and who developed in conjunction with others, developed the software. But really the reason behind this was that there's been a big push in Australia and I think internationally to try and get people with fractures to be treated, essentially, to be assessed and treated, because it is well known that people with a low trauma fracture are usually treated in the hospital by the orthopedic surgeon, then go back home, and the next time they might represent to their general physician is usually for something else. And the fracture may or may not get mentioned, and usually doesn't get mentioned because it's been treated. And then the next time that person turns up is when they have a more serious fracture like a hip fracture. So there's been a push in Australia for services like fracture liaison services. And I think also in the United States and elsewhere, whereby people actively look within the hospital system at people who have come in with fractures so they can then be identified and treated. But that is quite a labour-intensive process because you need a person, whether it's medical or whether it's an allied health person, to go through medical records or to go through fracture clinics and identify the person. So the reason, the aim behind this study was to look to see whether we could develop using artificial intelligence, a software program that would read radiology reports to identify fractures. And this natural language processing tool was developed. It's more than just a rules-based system whereby you read the radiology reports and identify the word fracture or identify the word no fracture, because it's an iterative process and it goes through the radiology reporting system, how particular radiologists read the report. It has a set of rules, and then it reviews what the outcomes are and then amends the rules and to try and improve upon itself so that you can get to sort of a high specificity really and sensitivity of what the software process is doing. And in that way, try and obviate the need for as much time for a person to be there trawling through the medical records. So this tool, which we called X-Rate, that's the X-ray artificial intelligence tool, was developed at a hospital in New South Wales, Prince of Wales Hospital, and then underwent 3 steps. We had an initial validation of the tool itself with the radiology reports. Then we had a clinical validation. How did this compare in a 3-month period compared with the fracture liaison person who happened to be a medical registrar at this particular hospital, with them looking through radiology reports. So in the same 3-month period, the X-Rate would look through the emergency records or the X-ray reports and compare that with what the medical registrar had found and what had been referred by emergency to fracture clinics. And then we did an external validation in another off-site cohort where fractures had already been validated to see how the X-Rate, the tool, worked in a site where it wasn't originally developed. So the tool was developed at Prince of Wales Hospital and then clinically, then validated at Prince of Wales Hospital, clinically tested at Prince of Wales Hospital, and externally validated in a completely different site. And what we found was that the initial validation, the validation of the tool itself was highly sensitive and highly specific. When we then went for a clinical validation, we found essentially that it was very specific. It wasn't quite as sensitive. It had about 70% sensitivity, so that there were some fractures that the medical registrar picked up that weren't picked up by X-ray, and that was partly because of the way it was designed. It only looked at fractures that were reported in emergency rather than some that missed that system and went through to the hospital, which, you know, patients who were then admitted and the fracture was later reported in the hospital. And it was designed to pick up the more major fractures. It didn't pick up all the ankle fractures, for instance, but it was quite highly, it was also very specific. So it's not like it picked up fractures that were not there. But most importantly, while in that 3-month period, the medical registrar, and I know the figures are in the numbers, the exact numbers are in the abstract, picked up something like 70 fractures. X-ray picked up 3.5 times more fractures. So without essentially the need for a clinical person. But we had actually gone through and validated all of the records that it picked up and identified that they were clinically important fractures. And then when we used it off-site, and that was in the double osteoporosis epidemiology study, which is a long-running osteoporosis study where fractures had been previously validated through personal interview, we found that it was highly sensitive also, not quite as specific, sorry, highly specific, not quite as sensitive, but indicating that even though it hadn't been trained in that site, it could easily be used in other sites. So this is really very exciting because it means that there is another tool that can be implemented in the hospital system to help identify fractures. And then some of the time for the allied health and medical personnel can be used to treat those fractures that have been identified. What we've also found is because it is so efficient, this tool, I mean, it's going to swamp the hospital system. If we could identify 3.5 times more fractures than a person on the ground, there's going to be work done to incorporate it more fully within the medical record so that we can use this in an even more efficient way. But it really goes to show how big an issue this is and how we're going to need to rely on these types of artificial intelligence systems so that we will be able to identify fractures so that the resources, the medical resources, can be used to put in to treat those people.
How can tools like this be implemented for physicians to use now?
So that's already being done. So there's within Australia, within Sydney anyway, there are other hospitals who have the license for this tool, and it is starting to be rolled out in selected places, and there's sort of discussions going on about how this might be the case. But the tool is there and ready. So it just requires that it be compatible with the hospital information system and the the IT that the hospitals use for identifying the for implementation within the actual radiology system itself. So that's a bit of computing work that needs to go on, but it's very possible because it's already implemented in this one hospital, and it's been shown that it can be implemented in several other hospitals already, which is being done.
How else can AI be used to improve bone health or identify fractures?
Well, there is a lot of work on other AI, which is going a step further, if you like, looking at the radiology itself, not just the radiology reports, but the X-rays and CT scans. And there are several companies around that have done that, and we've actually tested it in another study, one of those systems whereby artificial intelligence is used to identify the fracture from, say, a CT scan of the chest. And then that can be used as we're not saying that radiologists are not important. Of course they're important, because they need to actually make the clinical identification of that. But that could be used as a prompt, for instance, to the radiologist to mention the fracture. Because what happens is that someone comes in for perhaps pneumonia, and so the question put to the radiologist is this pneumonia? What's happening in the patient's lungs? And the radiologist is focused on the lungs and reports the lungs. He or she may or may not have noticed, or and probably has noticed, that there may be a compression fracture of the vertebra there, but that was not the clinical question that was asked. So that, depending on the individual radiologist and depending on the hospital, perhaps that may get reported, or it may not get reported. That may get then picked up by the lung physician who's looking after the patient, or it may not get picked up by the lung physician who's looking after the patient. But if an artificial intelligence tool can flag this and say, hey, this is a fracture, report it, and it's reported in such a way that the lung physician realizes that it needs to be passed on to someone else to then be investigated, then we will be starting to make a deep inroad into picking up a lot of osteoporosis that's not currently identified.
Is there a training process for how to use technologies like this, or is it pretty much, this is a simple thing to use?
So the training process comes in developing the actual technology. Once the technology has been developed, and once it's been tested, because of course it has to be tested for how sensitive and specific it is. One of the things that it was really important is that it cannot hold up what the radiologist is doing, because if it wastes the radiologist's time and picks up things that are not there, then that's not any help at all. So it has to be thoroughly tested as to how it would work and how it could be implemented in a way that does not disrupt the radiologist, so that he or she can, or may or may not use it, but it needs to be something that can be helpful to the radiologist. So it has to be accepted, be able to be implemented within the radiology information system within that particular hospital. Now, some of them, there's some systems that are sort of quite common among hospitals, some have separate systems. So again, as with reading radiology reports, which is a simpler sort of system, it has to be integrated within the information system within the hospital, and then has to be seen whether or not that can help within the workflow of the radiologist. So that has to be tested, but to actually be implemented is not so difficult. But it is IT work that's required. But there is a lot of this being developed now, and that's really exciting, because that should be really able to help with clinical identification of important medical conditions.
Is there anything else that you would like to add about the promise of AI for fracture identification and bone health?
And really, I think the bottom message is that the system that we have now, where there's an individual person that trawls through medical records and trawls through fracture clinics to try and identify fractures, is very time consuming and not that efficient, and that we can use AI to make better use of clinicians' time to actually treat the people, when AI can be used to help identify fractures.
Thank you so much for joining me today.
That's my pleasure. Thank you for asking me.